Hi, Mr. Roger. My name is Anu Verma. I am a student at United States University. I just washed my hands and I'm here to do your thorax examination. Can you say your full name and your date of birth, please?
Rajesh Verma, March 12th, 1962.
Thank you so much. I would like to get your permission to do examination of your upper thorax and lungs, and I would like to record a video so that my instructor can watch it and evaluate me. So can you give your permission for that?
Yes, sure.
All right. So looking at you, I see that you look normal, non-toxic. I don't see any pallor on your skin, no jaundice. Then there's no cyanosis on your face. The lips look pink. You are alert and oriented. You don't have any history of emphysema, tobacco smoking, or asthma. Looking at you, your chest muscles look. I'll have you come up front. You're not using any accessory muscles. You can take a deep breath for me and in and out. And I don't see that you are using any accessory muscles. You're not doing diaphragmatic excursion. You are not doing any chest wall, using any chest wall muscle exertion. There's no retraction of the intercostal spaces. Let me look at your hands, please. There's no clubbing of the fingers. There's no nail nicking. Also, there's no. I don't see that there's no Janeway lesions. And the color of the hands is normal pink and no cyanosis or pallor. After that, we're going to come to doing palpation. Oh yeah, I want to also check your the lateral borders of your chest, the lateral length of your chest, and the anterior-posterior diameter of your chest. And I see that the anterior-posterior versus the lateral length is 1:2, which is normal. Your respiratory rate is 16, which is taken by my assistant, and which is also normal. I'm going to now do palpation for you. When I do palpation, I'm going to touch you, and palpation, the midline of your trachea is in the middle. I don't see any masses or lumps or bumps. And when I do palpation, I am also okay, so I am going to do when I do the palpation, actually I'm going to do for the first palpation, I'm going to do check your respiratory excursion. For that, I'm going to put my hands on the lower part of your rib cage, and with my thumbs next to your xiphoid sternum, and take a deep breath, please, in and out. I see that my thumbs moved about 2 centimeters, which is normal, and they're symmetric on expansion. I'm going to have you move up front. I'm going to thank you so much. So now I'm going to put my hands right next to his lower rib cage here, and then I'm going to ask him to take a deep breath, please. One more, please. Okay, I see that my thumb moved about 2 centimeters. That means your respiratory excursion is 2 centimeters right there. Okay? And then now I'm going to check for tactile fremitus. I'm going to have you come back. For tactile fremitus, I'm going to use the outer surface of my hand, and I'm going to start right above the clavicle. And you're going to say 99.
99, 99, 99, 99, 99, 99,
Awesome. I'm going to go back.
99,
Yeah, here I'm putting my hand right above the scapula. And I'm going to have you actually, if you don't mind, folding your arms like this and then putting your hand right above the shoulder, please.
99, 99, 99.
Awesome. So this actually showed me the transferring of the sound, transferring of the sound to through your chest wall. Now I'm going to check the costochondrial, check you for the costochondrial tenderness, for which I'm going to put my fingers next on the sides of the sternum, right where you have the costochondrial cartilage. I'm going to put some pressure. Do you have any pain?
No.
Any pain?
No.
Awesome. I'm going to use my non-dominant hand is going to sit flat on your chest, and usually between the intercostal cervix, and then I'm going to use my dominant hand finger, and I'm going to tap it. The right hand, which is my dominant hand, is going to strike on the middle finger of my non-dominant hand, and I have to keep my wrist loose for that. I'm going to start my percussion from above the right clavicular bone, so to get to the apices of the lungs. So then I'm going to go to the right intercostal space, right, left. I'm going to go to the left intercostal space, and then right intercostal space, second right intercostal space, third intercostal space, third intercostal space. After that, I'm going to go on the left side. I know it's the heart, so I'm going to go on the right side. I'm going to go a little bit lower, and then now I'm going to ask you to raise your hands, please, and put them above the hand. I'm going to go mid-axillary line. I'm going to follow a ladder pattern. Very good. You can bring it down, please. And I hear that that all his lung sounds are resonant. I don't hear any dullness. You can come, or hyperresonance. So you can come up front. For the back, I'm going to start my percussion from above the scapula. I'm going to ask the patient to fold his arms and bring your hand right above the shoulders here. This separates the scapula, so I'm going to start above the scapula and start doing my percussion, starting from the right side of the patient. 1. I'm comparing that both sides are equal percussion, and I am hearing resonant sounds on both sides. Yeah, thank you so much. You can bring your hands down. Okay, after that, I'm going to also check for your, since I checked that, now I'm also going to check for your diaphragmatic excursion at the same time. So that's going to be going from, for that, you're going to take a deep breath, please. And hold. So let's take a deep breath again. And hold. So I'm checking when the sound became dull, and I'm going to check it on both sides. So I see that the sound became dull at about here. So now you're going to you release your breath, and then take another deep breath, and then release. So I see that when I did I could have marked it. So when I see that when he took a deep breath, the diaphragm moved low, so the line was lower, and then when he released the breath, the diaphragm was higher. So so usually the diaphragmatic excursion is between 3 to 5 centimeters. For him, it was 3.5 centimeters. After that, I'm going to do my auscultation. I'm going to bring it like this here, please. For auscultation, I'm going to the auscultation should be done for a full breath. Auscultation is done with the stethoscope and the diaphragm of the stethoscope. We always listen for a one full breath sound, but for the purpose of examination. But for now, I may not hear a full breath sound because I need to just demonstrate it. I'm going to start from from above the clavicle to check for the apices of the lungs. And I'm going to have you take a deep breath, please. And on the left side. Second intercostal space outside the sternal border. Second intercostal space. Third intercostal space. Third intercostal space. Fourth intercostal space. Fourth intercostal space. Fifth intercostal space. And fifth intercostal space. On the fourth intercostal space, on the right side is very significant because there we are listening to the right middle lobe, whereas on the fourth intercostal space on the left side we are hearing the left lower lobe. After that, I'm going to go to the mid-axillary line. So here I was listening mainly to the mid-clavicular line, and here I'm going to listen to the mid-axillary line for the lower lobes. Then I'm going to go to the back. I'm going to ask you to fold again. Fold your shoulders here. Fold your shoulders here, and then I'm going to check for the C7 to T3. I'm going to check first for the upper lobes, and then from T3 to T7, I'm going to that's for the lower lobes. So basically, if you auscultate the back for the lower lobes, I'm going to go above the scapula. His scapula is separated. I'm going to start from the right side. Take a nice deep breath, please. In and out. Nice deep breath, in and out. After this, I'm going to check for egophony, which is telling us to check for consolidation. I'm checking for egophony, for which I'm going to ask the patient to say the sound E. So You're going to say the sound E or when my diaphragm touches your chest, please.
E, 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 E.
So all over, I'm hearing the sound E, which is okay. If I hear the sound A, that is abnormal. Thank you very much. That concludes my examination. I just want to add that when I did the auscultation, I was looking for ronchi and crackles and stridor, but I was hearing only vesicular sounds. On 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 percussion, I was hearing mainly resonance, no hyperresonance or dull sounds, and that's about it. Thank you so much.